Hi, my name is Kim, and on behalf of my team, I'll be presenting our multi-center validity study of 4 smartphone hearing test applications in the optimized and home environment. Hearing loss is an incredibly common presentation worldwide, with more than 20% of the world's population experiencing some degree of hearing impairment. Pure tone audiometry remains the gold standard modality for hearing assessment, but requires specialized equipment and personnel, which can make timely assessments difficult, particularly in the rural or resource-poor location. Automated audiometry is a type of hearing test whereby users can self-determine their hearing function. Previous studies have demonstrated some comparability between PTAs and automated audiometry for adults when it came to those with mild to moderate hearing loss. There are many methods for testing, with the simplest one requiring only the user's earbuds and a smartphone. Smartphone-based audiometry app offers a promising alternative for remote hearing evaluations, though past reviews include unvalidated apps and were performed in environments with ambient sound, which could have influenced the app's performance. Our study aimed to determine how accurately these apps perform both at home and in hospitals, could replicate PTA results, and whether they were feasible for patient self-assessment at home. So, we conducted a prospective multi-center validation study between August 2021 and March 2023, collecting data from 4 hospitals providing secondary or tertiary ENT and audiology care. Participants who were already attending our clinics for PTA were approached by the study team. Once consented, they were randomly assigned to one of 4 apps, 2 from the iOS operating system and 2 from Android. These apps were selected on the basis that they were free and available in the UK, that they also provided graphical outputs, and did not require participants to input any personal information. As shown in the diagram, the participants then download their randomly assigned app onto the personal devices and are instructed to perform the app hearing test once in hospital, inside a sound-treated room, and 3 further times at home, particularly on day 1, 3, and 7. It was recommended that the test were performed in a quiet environment to minimize background sound, and participants returned their results through a secure email address. They were also invited to complete a survey at the end. These were our inclusion and exclusion criteria. Participants were included in the analysis if they submitted at least 1 smartphone app hearing test. They were excluded if they had any active ear infection or profound hearing loss characterized by more than 90 decibel loss at 3 consecutive frequencies. An alpha priori power calculation was performed to examine correlation across repeats in different environments to compare PTA versus app. A t-test was used to compare app-assisted hearing testing at the hospital versus at home using the G-Power tool. Comparisons between the smartphone app audiometry and PTA with regards to ear-specific and frequency-specific thresholds were done at 0.5, 1, 2, 4, and 8 kHz. The average was also calculated. Test-retest reliability for app pure tone average thresholds was done for both optimal sound-treated conditions versus final at-home conditions, as well as first versus final results at home conditions. In total, 156 participants were recruited, although 17 had to be excluded as they failed to submit any data, leaving a net total of 139 participants representing 388 smartphone hearing tests and 772 ear app audiograms in total. 47% of the cohort submitted a completed dataset comprising of 4 app hearing test results. Once again, here are the specific applications that we tested, with examples of the graphical thresholds output on the right. Furthermore, the test-retest reliability was high when examining both the optimal noise-to-home condition and the first-to-final readings at home, with an intra-class coefficient score of 0.87 and 0.90 respectively. Now, this figure illustrates the frequency-specific differences between PTA and app hearing test scores, stratified by the 4 different apps. All apps tended to overestimate the severity of hearing loss, specifically at the lower frequency. Now, this could have been due to ambient noise, although the same finding was noted in the initial test done in the sound-treated room, which makes this quite unlikely. It could also have been because of poor calibration or quality of the earbuds. Nevertheless, this disagreement was least pronounced for Android number 2 in the bottom right. The median result of iOS 1 and number 2 were also within 10 decibel hearing loss of the gold standard PTA across all 5 frequencies. This table compares peer-to-peer averages between app audiometry performed in optimal conditions in hospital versus at home, as well as the individual stratification by each individual application. There was moderate correlation between app audiograms performed in hospital versus PTA, with a correlation coefficient score of 0.56. This improved to a rating of strong when patients performed the test at home, with a score of 0.68. Peer-tone average thresholds of Android number 2 showed very strong correlation with the PTA, with a score of 0.83. iOS 1 and Android 1 showed strong correlation scores of 0.77 and 0.69 respectively. iOS number 2 showed moderate correlation score of 0.47 only. We had a response rate of 33% for the online feedback survey. 91 of those agreed or strongly agreed that the smartphone app was easy to use. 87 agreed that they would be happy to use the app to monitor their hearing function in the future. 83% agreed that they were able to find a suitably quiet place to use the app. To our knowledge, this is the first study to report the validity of self-conducted smartphone hearing audiometry testing platforms at home. We found strong correlation between the hearing thresholds by PTA at the hospital and those of home smartphone hearing tests. This finding related to a diverse group of adults across multiple centers with hearing loss of variable severity and etiology, and thus supported the ongoing use of development of home smartphone audiometry. More importantly, the tests were very consistent when repeated at home, showing good precision and reliability over time, which is quite handy for disease monitoring or facilitating research exploring the changes in hearing. We noted a tendency for the threshold on the right ear to be better than the left. In further investigation, the right ear was tested first in 3 different apps, so this may just reflect fatigue or poor concentration as testing progressed, which could normally be detected or corrected by the audiologist in the hospital setting during PTAs. Our peer-tone average accuracy was greater than 70% in 3 out of the 4 apps, with Android number 2 performing the best. Limitations included the restriction options for apps in the UK and only testing the apps once in the soundproof rooms. In conclusion, patient-conducted audiometry is increasingly desirable with a move towards remote care, as shown in COVID-19, as it can improve accessibility for those patients. 2 of the 4 apps reach accuracy that was considered clinically reasonable and therefore may be appropriate for use in a clinical setting. The high precision suggests that they may most appropriately be used to remotely monitor for fluctuations in hearing, rather than relying on the absolute hearing thresholds alone. Ultimately, both the patient and clinicians must be aware of the limitation associated with the apps. Apps cannot be used to replace PTA, as they overestimated the true levels. Clinicians should also be cautious not to recommend unvalidated apps. Finally, here are our references, and we do invite you to use the QR code to have a look at our paper to get a better understanding. Thank you very much for your time.